Welcome, my friends. Again, I'm Salah Abbas. I'm your tutor for clinical surgery. I chose an important and extremely common topic for today, and that is called acute diverticulitis. It's a very common emergency admission compared with all other causes of abdominal pain. It's probably the commonest admission caused by large bowel disease on a surgical admission day. Um, so we will explain to you how we deal with diverticulitis, and we will explain the pathology and the management of diverticulitis, whether it's complicated or uncomplicated. Now, a diverticular, in general, is a pouch that protrudes through the wall of a hollow organ. And if we apply that to the colon, then it's more or less a false diverticulum because it's composed of the mucosa and submucosa protruding through the muscle wall in between the tinea, and that's being held together from the peritoneal cavity by the serosa. So it's an incomplete diverticulum or a false diverticulum by definition. This condition is extremely common. It affects the colon, and the most common site is the sigmoid colon. And from a historical point of view, it seemed to be a byproduct of the Industrial Revolution. It's extremely common in Western society, where the diet is high with fat, high protein, and low fiber. The reason was thought that it is caused by the Industrial Revolution because first reports of the disease appeared about a quarter of a century following the invention of the roller milling of wheat, which led to the production eventually of white bread, where the fiber in the wheat got removed through these milling machines. And that by itself might be a reason. Also, the fact that we consume more food that contains high quantity of processed sugar and fat, and generally low in fiber. It does increase the incidence of the disease, or the particular disease by itself, does increase with age, to the extent that almost 2/3 of people at the age of 80 or so will acquire the disease. And the overwhelming majority of these patients who have diverticular disease, they will be more or less asymptomatic. It's important to understand the pathogenesis of the diverticulum. As you see in the picture here, it's outpouching of the mucosa, submucosa, and the serosa, and usually occurs at the site of penetration of the wall of the colon by an arteriole, which is more or less an end artery that supplies the wall of the colon. That point seems to be the weakest point. So we've got tinea coli on the anti-mesenteric side and one on the right, one on the left. And here's the mesentery, and the diverticular can happen in between these three columns of tinea coli. As of the reason why how does it happen and we get formation of these pouches? It's thought that the reason mainly is poor motility of the colon, or coordination of the motility, that will lead to increased intraluminal pressure. Now, the sigmoid colon is the narrowest part of the large bowel, and because of that, according to the Laplace law, it will be the weakest part. It will generate the highest intraluminal pressure, and that's where you see the diverticular. Having said that, diverticular disease can affect any part of the colon. including the right colon, the transverse, the descending, and the sigmoid colon. We also notice that these patients do have muscular hypertrophy as a result of the motility problems, and that's usually confined to the sigmoid colon rather than the rest of the colon. And as I mentioned earlier, the muscle hypertrophy is caused by low fiber diet with the consumption of highly processed food, and that's thought to generate increasing intraluminal pressure that will push the mucosa through the wall to form these pouches or diverticular, where occasionally some of the particles of the fecal matter get stuck inside these pouches, which will lead to diverticulitis. Here I have got for you the appearance of diverticular disease in the colon on colonoscopy. So that's how it looks on endoscopy. They are just bland pouches. And as a result of impaction of fecal matter in there, this could lead to development of the process of diverticulitis as a result of bacterial growth in that part of the diverticulum that's not drained and blocked by fecal matter, and that will lead to bacterial overgrowth and extravasation of the content of the diverticulum. So basically, it's a very localized microperforation at one site in the colon in one of these pouches that will spread the inflammatory process, which will lead to what we call diverticulitis of variable severity. So more or less, the process of diverticulitis does follow the same rule that we get when we have appendicitis as a result of the appendix being occluded with intraluminal fecalith. So the process is totally an infective process, and the mildest form leads to some abdominal pain, and when you do a CT scan for them, you find stranding of the fat around the colon. Now, how do they present? How do these patients present to us? Usually they present with an acute abdominal pain. The pain will be of gradual onset and variable severity, but the pain will build up over a matter of a few hours and usually starts in the left iliac fossa. Could be generalized pain, but most likely to be a left iliac fossa or across the lower part of the abdomen below the umbilicus. It can radiate to the back and causes back pain as well. Pain in the suprapubic region and in the groin is relatively common, and that's related mainly to the position of the colon that get affected, which is the sigmoid colon. Now, systemically, when you look at the patient, they feel unwell, they might have high temperature, they might have tachycardia, and if it happens, you put a urine catheter to manage them, and they might have low urine outputs. Now, this depends on the severity of the diverticulitis. Not all patients will follow the same clinical course. How do we manage them? We examine them. Now, physical examination of patients with diverticulitis tend to be variable. As I mentioned, they might have temperature. Usually, they will have tenderness in the left iliac fossa, the suprapubic region. That will be associated with signs of peritonism in the form of guarding when you feel their abdomen. That's in case of localized form of diverticulitis. But every now and then we see a patient who develops severe form of diverticulitis, which will lead to excessive peritoneal soiling, and that could present as rigid abdomen with acute peritonitis. And these are the patients that will need to have an emergency surgery. Occasionally, when you feel the abdomen of a patient with diverticulitis, you could see or you could feel a mass in the left iliac fossa or the suprapubic region, and that's caused by the phlegmous inflammatory process that will involve the mesentery, and usually there will be some momentum moving toward the area trying to contain the infective and inflammatory process, and that can lead to mass formation. We take their bloods, and as expected, they have high white cell count and high CRP of variable degree. And then the basic bloods will also need to be done, and that will include urea, electrolytes, their coagulation, and also test their urine to ensure they don't have a urinary tract infection as a cause of the pain. And then you scan them. We usually do a CT scan of the abdomen. Now, the CT scan of the abdomen is crucial, and we use it in every single case of acute diverticulitis, and that's not only to establish the diagnosis, but also to establish the severity. Now, the severity or the grade of the diverticulitis can be divided into 4 grades, and this is called the Hinchey classification or grading system of diverticulitis. Now, grade 1, when you have just a colic inflammatory process, so the process of perforation and infection, and the inflammatory process, the whole process is limited to the area surrounding the colon without any spread of the infection elsewhere. Now, grade 2 is usually an abscess formation, and that abscess is usually in the pelvic region, and it would be walled off abscess, which might be suitable for percutaneous drainage. Now, grade 3, when they have relatively severe pancreatitis in the form of purulent peritonitis, and that might need a surgical intervention in the form of a laparotomy and a sigmoid colectomy. And also grade 4, it's fecal peritonitis, where there is a lot of fecal matter soiling the peritoneal cavity, and this tends to be the most severe form of diverticulitis, and that will require surgical treatment. Now, the overwhelming majority of people who get diverticulitis, they get what we call uncomplicated diverticulitis. And that defines any patient who get diverticulitis localized to the colon. So basically grade 1 of the Hinchey classification system. These patients will need admission to the hospital with intravenous antibiotics. My favorite antibiotics in this situation is tazocin, and it's given in the form of 4.5 gram 8 hourly. The dose might need to be adjusted according to the renal function of the patients, but majority of people will have normal renal function and will have that dose of tazocin. Another alternative, because tazocin sometimes is not available, it's relatively more expensive, we put them on ceftriaxone, which is given once daily in the form of 1 gram. We usually add metronidazole in that situation intravenously as 500 milligram every 8 hours. Now, these patients will often have the response to the antibiotics and the painkillers, and we leave them either null by mouth or just sips of clear fluid until the pain starts to improve and settles down. It will need the patients a minimum of 48 hours to 72 hours to feel the difference that the pain is improving, their inflammatory markers are coming down, and they are not running temperature, and they have their bowel moved and tolerated some light diet. We usually give them some soft diet within about 48 hours after the admission. It could be longer, depends on patient tolerance to the oral intake. And once we are happy clinically with them in the form of the pain settled, no temperature, inflammatory markers are trending down or low, then we can switch them to oral antibiotics. And the most common antibiotics that we use is augmentin duofort in the form of 875 milligram 3 times a day. But most patients, if we are not using the intravenous regime for augmentin, they could go on twice daily dose of the same antibiotics. Usually, I prefer them to have about a week to 10 days of full antibiotics, and the majority will settle down. We get a dietitian involved to teach them, because often these attacks of diverticulitis are precipitated by a period of constipation where hard fecal matter will occlude one of these pouches that will lead to the diverticulitis. And the dietitian advice is quite helpful to the patient, and it is very reassuring. Now, complicated diverticulitis, we have basically two forms of complicated diverticulitis, at least, that can occur. The first one is the abscess formation, which is grade 2. These patients will be treated with antibiotics, and as you see on this CT scan, there is a collection in the pelvis just around the sigmoid colon, and we could see the diverticular in the colon as well. These patients will have intravenous antibiotics. If the abscess is bigger than 3 centimeters, then we advise to have a percutaneous drainage, which is guided with a CT scan or occasionally with ultrasound, depends on the location of the abscess and the preference of the radiologist. If they are less than 3 centimeters or they are inaccessible, we persevere with the antibiotics and see if we can improve on the situation to drain the abscess later on. Very occasionally, you find a formation of abscess in the Douglas pouch, which is, or rectovesical pouch in men, and then it could be amenable to transrectal drainage, but it has to be in a favorable position. And when you examine the patient under anesthesia, you could actually feel the fluctuation of the pus and the rectovesical pouch, and then you can drain it transrectally, and it seemed to heal very well. Now, any patient who gets complicated diverticulitis, particularly if they had an abscess formation, we often advise them to have surgery, because they could develop recurrent severe attacks of diverticulitis. And these patients might benefit from a sigmoid colectomy, but the majority, rather, of the of people who get admitted with diverticulitis will follow the conservative, non-operative measures, and we generally recommend doing a colonoscopy for every single attack of diverticulitis, unless the patient had a recent colonoscopy, and by recent it just means basically the last 2 years or so. We wait for the diverticulitis to settle down completely, and the landmark of settling down of any inflammation is 6 weeks, and then we do a colonoscopy to rule out the presence of underlying malignancy, because we know they have got diverticulitis. We're not there to diagnose diverticular disease. We are there to ensure that there is no colon cancer masquerading as diverticulitis. Now, patients with severe complicated diverticulitis, where they have a free perforation in the peritoneal cavity, whether purulent or fecal peritonitis, these patients are unwell. When you do a CT scan, they will have a lot of free gas in the abdominal cavity, and usually a significant amount of fluid as well, which indicate free perforation. They tend to be quite unwell with rigid abdomen, and then they go to the operating theatre for a sigmoid colectomy, and usually formation of a stoma, which is called the Hartmann operation. Now, one of the complications that could arise, and this is a chronic, a long-term type of problem that could happen after a moderately severe attack of diverticulitis, particularly these patients who have an abscess that can lead to necrosis and erosion through the wall of the bladder or the vagina in females, and rarely it could go to the skin or the small intestine. So a fistula is a significant problem particularly if it goes into the bladder or the vagina or the skin. Perforation into the small intestine and formation of colointestinal fistula that usually manifests in the form of severe diarrhea. Very unusual situation though to have, and almost all these conditions we will end up operating on them to cure the fistula. Now, the most common one that we see is colovesical fistula. These patients tend to have recurrent UTI, and particularly in a male patient who had history of diverticulitis with recurrent attacks of UTI. Also in women, if there is vaginal discharge, they will be able to tell you as it looks like fecal matter and smells bad, and that will bring to your attention the possibility of having a colovaginal fistula. Now, it's important to notice that in women who had previous hysterectomy are the patients who are likely to develop colovaginal fistula, as the uterus tends to protect the vagina from any communication with the colon. The diagnosis of colovesical fistula or colovaginal fistula is often quite difficult. So these patients will need to have a colonoscopy, number one, to ensure they do not have any underlying cancer that might be masquerading as a diverticular disease, and you could mistake that for complicated diverticulitis. Now, doing the colonoscopy is very unlikely to show you where the fistula comes from, but it will rule out underlying cancer and will confirm the diverticular disease. These patients will, of course, get a CT scan, and the most common sign that we see is a free gas bubble, as you can see on the CT scan, a free gas bubble in a dependent position when the patient is lying down. It is floating up, and that's almost always mean that there is a colovesical fistula that will need treatment. Occasionally, we could use a CT scan with rectal contrast. The yield of that is small, but sometimes it could demonstrate the appearance of the fistula. MRI is another modality that is underutilized to detect the fistula between the bowel and the bladder. But the diagnosis tend to be relatively hard because the anatomy can be tricky to interpret. If you do a cystoscopy for them, and they will have, and we manage these usually in association with a urologist, there is a possibility that sometime you could demonstrate the fistula. Another thing that can be done is putting methylene blue in the bladder and see if you can see that in the colon on colonoscopy after putting a catheter and filling the bladder with about 200 to 300 mils of saline with 5 mils of methylene blue. So this is combined colonoscopy plus either cystoscopy or urine catheter to see if the methylene blue dyes can cross the bladder when the bladder is full into the intestine. Other than that, if the patient is suffering from the typical clinical features and the CT scan shows gas in the bladder, which is free gas, then they will often get taken to the operating theater for a sigmoid colectomy to eradicate the problem. And you'll find that at the time of the operation, it's difficult to identify where the exact track of the fistula is, which means that you just do resection of the sigmoid colon, and leaving a urine catheter. Even if you don't find the hole in the bladder without suturing that, leaving the catheter in the bladder for 10 days to 2 weeks will lead to healing of the fistula, and you don't need to do anything more. Occasionally, patients with diverticulitis can present with bowel obstruction, and that bowel obstruction can take two forms. Either a small intestinal obstruction as a result of formation of a phlegmon or an abscess in the pelvis or around the sigmoid colon, and the small intestine can get trapped in that inflammatory process, which could lead to small bowel obstruction. Majority of these will settle down on no operative treatment, just with antibiotics and observation, and letting the problem settle down without operating on them. It could also lead to large bowel obstruction. That can be a tricky problem because these patients usually present acutely with large bowel obstruction. You do a CT scan for them, and you see the colon is distended with gas. The cecum is very distended as well, and you will be able on the CT scan in different planes to be able to see the transition point of the obstruction between the normal caliber and the dilated colon. Now, whenever a large bowel obstruction happens, we always think that it's more likely to be cancer than stricture, because diverticular strictures do happen, but they are a lot less as a cause of large bowel obstruction from bowel cancer. Now, these patients in general, they will need a colonoscopy. After the CT scan, we need to go in and have a look with the colonoscope, and if we see cancer, then we take biopsies to confirm the diagnosis. If there is no cancer and the colonoscope could not be passed or driven past the point of obstruction, then that's considered as a complete obstruction, and they will need operative treatment in the form of a sigmoid colostomy and usually the formation of a temporary stoma. Now, we do face a problem of recurrent attacks of diverticulitis. No very common condition, but we see enough of that. People who get diverticulitis and they get treated with antibiotics and they settle down, and they will have more and more frequent attacks. These are the exceptions rather than the rule, but it is an important category of these of patients. And those who have very frequent attacks, it can have a significant impact on the quality of their life, which means that they often get offered a sigmoid colostomy. Another category of patients who might have recurrent problem is those who have at least a single complicated attack, which means that there was an abscess formation. These patients, again, are candidates for surgery. Now, what do we do to them in terms of surgery? If we are doing an acute emergency surgery for perforated diverticulitis, we do sigmoid colostomy, and we could put an end colostomy. And that colostomy often is temporary, unless the patient is frail or elderly or those with comorbidities. They will probably stay with their colostomy for life. Surgeons could sometimes choose to do a primary anastomosis, and that depends on the course of the operation and the severity of the infective process inside the abdomen. Often the patients, when they are perforated, they are sick. We prefer just to do an end colostomy, but there is an option that we could do a colorectal anastomosis, where we anastomose the descending colon to the rectum, and if we are worried about the anastomosis, we do a covering loop ileostomy, a temporary covering loop ileostomy until the patient heals, and then we bring them back and do a colonoscopy to ensure healing and no other lesions in the colon, and then we reverse their ileostomy. Another category of patients that could face recurrent attacks of diverticulitis and need surgery are those who are immune compromised on methotrexate for rheumatoid arthritis or other cytotoxic agents for organ transplants. They tend to have severe attacks of diverticulitis, and they tend to recur, and they do better with an elective sigmoid colectomy with or without anastomosis. Depends on the discretion of the treating surgeon. Well, friends, I hope this has been a useful lesson. Please leave us your comment, and I will be more than happy to answer any questions in the future. Thank you very much, and good luck in your endeavors.